Hi, everyone. Welcome to another Monty Heart lecture. It's a real pleasure to have today Dr. Nadine Choueiter with us, who will be giving the last lecture of the year. Actually, we're going to be taking a small gap for the holidays. She will be speaking about a very important topic, Kawasaki disease, from childhood disease to adult outcomes, what the adult cardiologists need to know. So it's a real honor to have Dr. Choueiter here with us today. She's originally from Lebanon. She did pediatrics at UT Southwestern, then cardiology at Seattle Children, and advanced imaging at Boston Children's. Dr. Choueiter is a professor of pediatric cardiology and radiology and the director of the Congenital Cardiac MRI program at the Icahn School of Medicine at Mount Sinai, where she also co-directs the Kawasaki disease follow-up program. She's a nationally recognized multimodality imager with expertise in cardiac MRI, echocardiography, and fetal imaging. Dr. Choueiter has led and collaborated on influential research through the International Kawasaki Disease Registry and the Kawasaki Disease Arab Initiative. We know Nadine very well, as she used to be with us at Monty. We know she's an excellent doctor, so it's a real honor to have you here with us. Thank you so much.
Oh, thank you for having me, Leandro. It's such a pleasure to be back at Monty. I was there for 12 years, I think. So I have no disclosures, and over the next 50 minutes, I'll provide an overview of Kawasaki disease, how it's diagnosed, what are the cardiovascular sequelae and complications, long-term management, and how do we manage acute coronary syndrome and Kawasaki disease, and how different it is from adults with atherosclerosis. And finally, how do we bridge the gap? And the goal behind the talk is to ignite the interest of adult cardiologists in this disease, because our patients are growing and we need to partner to provide the best care possible. So Kawasaki disease was first described in Japan by Dr. Kawasaki in 1967. It is currently the most common cause of acquired heart disease in children in North America, as well as in Asia, such as Japan and Taiwan, and I'll show you in a minute. It is an acute self-limited vasculitis of unknown etiology, yet we know it has a predilection for the coronary arteries, and coronary artery aneurysms occur in 25% of untreated children and in 5% of treated children. It may lead to myocardial ischemia, sudden death, or ischemic heart disease. This is from the surveillance that is done in Japan every few years. This is up until 2022. And you can see a steady increase in the number of Kawasaki disease patients from 1967 up until 2022. You see a slight decrease around the pandemic, but we did see that even here in the US, which talks about whether there is an environmental agent that might put some children who are genetically predisposed to develop this autoimmune response. If you look at the global epidemiologic distribution of Kawasaki disease outside of Japan, first you can see that in Japan, the rates are almost, if you compare the rates of 300 per 100,000 to the rates in the USA, you can see the huge difference. And you see that it's mostly in Japan and Korea, but you can also see that it is definitely prevalent in Canada, United States, so North America and Europe. And I want you to pay attention to the fact, and that is important for the end of my talk, that literally when you look here, okay, you don't see any Arab or African country on there, because there is no epidemiological data of Kawasaki disease in that part of the world, and that's pretty concerning. In adults, we know that in patients with suspected acute coronary syndrome, this is a study from Taiwan. We can see that the prevalence of these young adults who present with suspected acute coronary syndrome who go to the cath lab, 7.5% of those patients are thought to have had Kawasaki disease in the past, based on the coronary artery affected, the segments, Usually it's the proximal segments and based on the characteristics of the lesions that we will go over in a minute. Similarly, a study done in San Diego shows that in adults younger than 40 years of age who present with suspected MI, 5% of those are thought to have had Kawasaki disease. There is no specific blood work or lab test or imaging test for that diagnosis Kawasaki disease. The diagnosis is purely clinical. These are children between 6 months to 6 years of age in the majority of cases who present with fever persisting at least 4 days. Okay. With presence of at least 4 or to 5 of the principal features that you see here, which is the bilateral limbic sparing conjunctivitis, the swelling and the redness of the hands and feet, usually it's the palms and soles, the red cracked lips and the strawberry tongue, a solitary cervical lymph node that's more than 1.5 centimeters, and a generalized rash. A history of a rash counts. The rash is usually, there's any type of rash, it's just not a petechial rash or a pustular rash. And it's important to exclude other diseases with similar finding. And when you have a child who presents with fever, you have to have a high index of suspicion because viruses can present this in the same way. Some supportive findings are lab and clinical, include irritability. These children are very irritable. They're tachycardic. There's an increase in white count with left shift. Thrombocytosis, usually not necessarily on presentation, but usually within 2 weeks. An increase in inflammatory markers, ESR and CRP, anemia, eosinophilia, hypoalbuminemia, hyponatremia. There's sterile pyuria, which is white count in the urine, white blood cells in the urine without any bacteria, and transaminases, and increased white blood cells in the synovial fluid. Now, not all children present with the complete form of Kawasaki disease that I just described. Actually, patients present with incomplete criteria, and these are the patients that are at a higher risk of aneurysms because often the diagnosis is delayed. These are children that present with fever between 4 to 5 days and 2 or 3 of the compatible clinical criteria I just described, or infants with fever for more than 7 days and without any other explanation. If the inflammatory markers are high, the CRP and the ESR, and 3 or more of the lab findings that are in this table are met, then this patient should be treated for Kawasaki disease. If the lab findings do not support that diagnosis, then an echocardiogram is performed. And on the echo, what you're looking for, a positive echo, is an echo that shows coronary artery aneurysms. Usually it's in the RCA and the proximal LAD, which are the 2 arteries that are most commonly affected. And their dimensions are, when normalized to body surface area, we generate a z-score doing that. Usually that z-score is more than or equal to 2.5. That qualifies as an aneurysm. Or if there are 3 or more of the following findings: LV dysfunction, MR, pericardial effusion, and just mild dilation of the coronary arteries with a z-score of 2 to 2.5. And that definition of a positive echo speaks to the fact that Kawasaki disease is not only a disease of the coronary arteries, or not only affects the coronary arteries, it affects the myocardium, the pericardium, and the valves. And it also is important to mention that the echo rarely makes a diagnosis of Kawasaki disease. It's there to tell us about the cardiovascular sequelae of Kawasaki disease or involvement. So as we advise our pediatricians, and we strongly urge them that when a diagnosis is suspected, to treat, okay? And not to wait for the echo. And that's because a delay in diagnosis results in an increased risk in coronary artery aneurysms. Patients are treated with IVIG, 1 infusion, 2 per kilo, within the first 10 days of fever. After 10 days, it's considered delayed treatment. Moderate dose aspirin is also added. And then the patient is switched to low dose aspirin until there's no evidence of coronary changes. That's for its antiplatelet activity. 15 to 20% fail to respond to IVIG. They're called IVIG resistant, and the risk of aneurysms is 6 to 7 times higher in non-responders. Now, because I'm addressing adult cardiologists and you're not going to be dealing with this disease in the acute phase, I'm not going to go over the management of IVIG resistance, but just to know that there is a push towards aggressive treatment, not only with IVIG, but intensifying with other immunomodulators in those less than 6 months of age and those with positive echoes in their first echo is positive, shows aneurysms. Not only do we give IVIG, we give other immunomodulators as well. So as I said, it is a disease of the cardiovascular system, the coronaries, myocardium, pericardium, and the valves, and the aorta. Myocardial dysfunction occurs in 20% of patients. It's associated with aneurysms. It's usually mild and resolves within 6 to 8 weeks. Pericardial effusions can be seen, but hemodynamically significant effusions are rare. And in terms of valves, the mitral valve is usually affected in 60%. What you see is MR. It does resolve within a year in the majority of cases, and rupture of the cordes is very rare. In terms of the coronary arteries, you can see here, this is a nice diagram to show you the type of insult that happens. So they're in the acute period, and we start with a normal coronary artery, and the artery can have mild transient dilation or no dilation. But when an aneurysm is formed, there is a necrotizing arteritis that happens in the acute phase. And that can lead to either a thrombus formation with complete occlusion by a thrombus, a layered mural thrombus, or remodeling by myofibroblastic infiltration and luminal myofibroblastic proliferation, where the arteries look quote unquote normal in size, but actually they tend to develop stenosis on each end, on the inflow and the outflow part of the aneurysm. And in terms of the thrombus, you could have a completely, you can have thrombotic occlusion. That thrombus can be permanently occlude the artery, or it can recanalize. It's important to note that the lesions, the coronary artery lesions, are different than adults with atherosclerosis. You don't see, this is a good paper by Dr. Gordon, who is an adult cardiologist, who is an adult cardiologist in San Diego. He actually retired, but he's one of the adult cardiologists who's seen the most adults with Kawasaki disease. And they describe that these are not, there's no lipid-laden macrophages and cholesterol crystals. Instead, there's intimal proliferations and neoangiogenesis. There's a concentric calcified stenosis, as I mentioned, on either end of the aneurysm. And there is impaired coronary function, and I'll show that later, even if there is no aneurysm. The aneurysms are usually proximal. They're not diffuse, similar to the aneurysms that you see in which is what you see in atherosclerosis. These are usually aneurysms that start in the proximal coronary arteries, and then you can have a beaded appearance to that coronary with distal aneurysm, but it always starts in the proximal coronary artery. And how are these aneurysms and coronary arteries diagnosed? I understand that it's hard for an adult cardiologist to see that, but we see coronary arteries on echoes in babies. And this is a parasternal short axis. You see the aorta, and you see a giant aneurysm in the left main, in the proximal LAD, and in the SIR. Echo is the primary imaging modality in the acute and subacute phase, which is up to 4 to 6 weeks. We take the luminal dimensions of those arteries on echo, the intraluminal dimensions, inner edge to inner edge. We normalize it to the body surface area, and assuming a normal distribution, we see how many standard deviation from the mean that measurement is when normalized. And that's the Z-score. No lesion is a Z-score always less than 2, dilation 2 to 2.5, or a Z-score variation of more than 1. A small aneurysm is between 2.5 to less than 5. A medium is between 5 to less than 10 with an absolute dimension of less than 8. And a large or giant is a z-score more than or equal to 10, or an absolute dimension more than or equal to 8 millimeters. The reason we do that in children is because a 3 millimeter artery in a 6-month-old is different than a 3 millimeter artery in a 6-year-old. And data has shown that if you use absolute dimensions and not z-score, you tend to underestimate the cardiovascular involvement and the extent of coronary artery involvement in these patients. To drive the point home, this is a 9-month-old who presented with classic KD. He presented late. He presented already with giant aneurysms, as you can see, in the left main, LAD and circ, and also in the right coronary artery. At 21 months, this was at the time a surveillance cath. Patient was completely asymptomatic, no EKG changes, no regional wall motion abnormalities on echo, no LV dysfunction, no new MR. You can see on this angiogram almost complete occlusion of the LAD, okay? This patient underwent a CABG at 21 months of age, and he's one of the youngest patients who have undergone a CABG here in North America, from the Lima to the LAD. At 4 years of age, again, the patient developed stenosis on either end of the RCA aneurysm and ended up with a drug-eluting stent. And this patient, this stent actually was placed at Montefiore when I was following the patient there. And just to show that in this particular patient, this is a patient who presented with delayed, it was a delayed presentation. He is probably, this is one of the most severe types of coronary artery involvement. That is what we're trying to avoid. Yet we got to this point, and the care of this patient was a team of both pediatric and adult cardiologists. So this was done in the pediatric cath lab with a pediatric interventionalist at the time and an adult interventionalist. So how do we follow these patients long-term? And what do we mean by long-term? Long-term is truly long-term. We're following them into their 30s, 40s, 50s, and 60s, and that's where you come in as adult cardiologists. On long-term follow-up, it's the way we look at it is how often do we need to see them? Who needs antiplatelet and anticoagulation? How do we assess for inducible ischemia to pick up on those patients with coronary artery stenosis? And how do we manage MI or acute coronary syndrome? So the risk or the coronary artery aneurysms are further risk stratified, and the follow-up in Kawasaki disease on the long term is tailored to the maximum z-score achieved in the acute period, which we discussed, along with the z-score at follow-up. So we further risk stratify them. So for example, a medium aneurysm is further risk stratified into current or persistent 4.1, regress to normal 4.2, or regress to normal or regress to small 4.2, or regress to normal or dilation only 4.3. And that applies to every category. In terms of cardiac imaging, so we've moved out of the acute and subacute period. We can see that other imaging modalities start to play a role. One, because the kids grow up, and two, because we're trying to answer different questions right now. We're trying to see, is there coronary artery stenosis? Can we see the distal coronary artery tree? Can we assess for inducible ischemia? Do we need an intervention? Do we need a cath? So those with normal or mild dilation, once the coronary artery aneurysm has, once the coronary artery dilation has resolved and the coronary arteries have stabilized, they're not followed, okay? The ones that you will see in your practice are the ones with persistent aneurysms, be it those with small aneurysms, and they usually are followed up to 5 years, but they may be discharged after 5 years. If the aneurysm resolves, there's a normal stress test and a normal coronary CTA. And then there's those with persistent moderate or large and giant aneurysms. They require ongoing follow-up. It's anywhere between 3 to 5 years. In those with giant aneurysms, the AHA statement suggests periodic stress imaging every 6 months to 1 year, and coronary CTA every 1 to 5 years based on the size of the aneurysm, symptoms, and what has the other imaging modalities have shown. So is it okay to discharge those with small aneurysms? This large study from the International KD Registry, there was 1,651 patients with aneurysms. It showed that those with small aneurysms by 1 to 2 years, the majority of them regress to normal or resolve. This is much less likely in those with large aneurysms and medium aneurysms. No major adverse cardiac events were seen in those with Z-score 5 or less, so in those with small aneurysms or normal or mild dilation. Yet it's important to note that an aneurysm that started as small and regressed is different than an aneurysm that started as large or medium and regressed to a smaller size. This is a study that went over 24 patients using optical coherence tomography, looked at their coronary arteries at 16 years later after their Kawasaki disease, and it showed disruption of both the tunica media and a thickened intima. For example, in the right coronary artery without aneurysm, that was a right coronary artery that didn't have an aneurysm, or an aneurysm that has regressed, and in an LAD with an aneurysm. So regression does not necessarily mean normal. Also, features of atherosclerosis were seen in those with persistent coronary artery aneurysms, more so than those with regressed aneurysms, and more so than those without aneurysms. So regressed is not the same as without. And what they've seen is calcifications, microvessel disease, cholesterol crystals, macrophage accumulation, and layered plaque. So what are the goals of advanced imaging? We're looking for coronary artery stenosis that will need some sort of intervention, managed medical or surgical, or in the cath lab, percutaneous. And then the choice of additional imaging modality, at least for us in the pediatric world, we're always trying to figure out what is the clinical question that we're trying to answer, because all of these are high resource settings for us. The age of the patient, do we need anesthesia? Do we not need anesthesia? What are the center's expertise and resources? And we're trying to minimize exposure to ionizing radiation because we're following these patients lifelong. So CT is often the modality of choice to look at the coronary arteries non-invasively beyond echo. There are centers that use blood pool agents and 3D data sets to look at the coronary arteries by MRI, and data has shown that it correlates well with cath. Yet it does involve a lot of coordination, and not all centers have access to that blood pool agent. So if you look here on the CT scan, you can see a recanalized RCA thrombus and a stenosis at either end of the aneurysm. These arteries can be calcified. We can get a calcium score. Often the calcifications is within the aneurysm, seen in those with persistent aneurysms, and the incidence increases with time. We know in adults with atherosclerosis, this is associated with an increased risk of MI. This hasn't been studied in Kawasaki disease, meaning its significance is not well known. In terms of inducible ischemia, who's at risk? We know again from the same international KD study that those are at risk are those with giant aneurysms. So those with Z-scores 10 and above. The 10-year cumulative incidence of major adverse cardiac events is close to 14%. And this is also has been shown in prior Japanese studies. Stress echo is, one of the less invasive stress imaging modalities to use. And in a single center study, exercise stress tests performed in 35 Kawasaki disease patients with aneurysms successfully identified those at risk for MI mainly risk level 4 and 5. And it can be used in children older than 7 years to screen for inducible ischemia. It's important to note, though, that our patient's heart rate drops really fast. So this has to be, when the echo is being done, whether we're doing if we're doing an exercise, which is exercise stress test, we have to account to the fact that the heart rate is going to be dropping very fast and we have to move fast. Stress MR has been definitely studied in Kawasaki disease and coronary artery anomalies in the pediatric population. It does require general anesthesia in children. It is a high resource setting. You can use dobutamine, and you can obviously, it's best to assess for perfusion in these patients using either low dose dobutamine, adenosine, and regadenoson. And this is a patient of ours who was 15 years old, known to have giant aneurysms, completely asymptomatic, though I have to, the disclaimer is this is also a patient who's morbidly obese and leads a pretty sedentary life. And you can actually see on this stress perfusion, you can see it here on the still image as well, is that there is a perfusion defect. This is in the mid myocardium at the inferoseptal wall, and there is at rest there is evidence of late gadolinium enhancement subendocardial in the mid inferior and inferolateral segments, consistent with a subendocardial infarction in the RCA territory. And when this patient was taken to the cath lab, you can see that there are multiple aneurysms, at least 2 in the proximal right coronary artery. It's completely occluded beyond the second aneurysm. And you can also see that there's a huge aneurysm on the left in the left system, and you can see collateralization from the left into the to the right. So this is a complex situation. This particular patient, we opted for medical management for multiple reasons, even though I wasn't truly this is almost like a ticking bomb. We have an RCA that's completely occluded, that's dependent on a left coronary artery that's eventually also going to become stenosed. But this was we opted to optimize medical management, anticoagulation, and weight loss management before pursuing other options. In terms of antiplatelets and anticoagulation, all patients with persistent aneurysms will be on low-dose aspirin. We would consider dual antiplatelets in those with moderate and those with large giant aneurysms. Anticoagulation is very important in those with persistently large aneurysms, whether it's with warfarin and Coumadin. And recently, direct oral anticoagulants have been studied and are being used more and more in Kawasaki disease. Obviously, you want to consider limiting contact sports in those on anticoagulation. Why do we do anticoagulation? This is the same study I showed before from the IKDR. There were 440 patients with giant aneurysms. Those who were not on any type of anticoagulation had a 20% risk of thrombosis, while within the first year, while those who were on anticoagulation, that risk significantly decreased. And this is a perfect example of what you see on the CT scan in a patient with a giant calcified aneurysm in the LAD and partially occlusive thrombus. Both edoxaban and apixaban have been studied and compared to standard therapy in children, including Kawasaki disease, for the primary prevention of thrombosis. Now, the events in both of these multi-center randomized trials were very rare. So the trials have not been able to establish superiority or inferiority of these agents compared to standard therapy, but they were found to be safe, and they required less monitoring and no subcutaneous injection. And we do often get hematology involved in the initiation of these medications. In terms of acute coronary syndrome, so the risk of MI is the highest within the first 2 years. You can see that this is data from Japan, and similarly data from North America. And that is important because these children are young and they're going to present NMI and they're going to present to a pediatric emergency room. And we hope that our pediatricians in the emergency room are aware of this disease. And we actually tell our patients with giant aneurysms when they present to the ED we give them a spiel. I have giant aneurysms, I'm at risk for a heart attack. We tell that to the parents or to the patient. And I'll tell you why in a minute. But we often involve our adult colleagues in the management of MI. Stable angina in KD, usually it's insidious, atypical presentation because the stenosis is progressive. They tend to form collaterals. And they're often found on testing for inducible ischemia. And again, the risk of intraluminal narrowing is most in those with giant aneurysms, and it increases over time. So when MI is suspected, it's infants and young children are going to present differently than adults. They're going to present with inconsolable crying, restlessness, pallor. Teenagers might present with abdominal pain and vomiting. Older children might present with chest pain. These patients are advised to go to the closest emergency room to get 12-lead EKG, troponin, IV access, coagulation labs, aspirin, morphine, and oxygen, and consider transfer to an experienced cardiac surgical center. If it's STEMI and the cath lab is less than 90 minutes, they go for PCI. And if it's more than 90 minutes or PCI is not possible because it's a small child, we would consider thrombolysis or CABG. And thrombolytic therapy for a fresh thrombus, it's usually with systemic TPA or bivalve. Once coronary flow is restored, then you would consider, do aspirin, clopidogrel, or eptifibatide, beta blockers, statins, and ACE within 24 hours. In non-STEMI, you would start heparin, serial troponins, ECG, urgent imaging. And if it's a thrombolysis, you would do thrombolysis or PCI. If it's stenosis, PCI or CABG if necessary. And it's important for centers that care for a population of Kawasaki disease patients with aneurysm to have a heart team that's made of pediatric and adult cardiologists, pediatric and adult interventionalists, pediatric and adult cardiac surgeon. How does PCI fare versus CABG in Kawasaki disease? This is a multi-center survey from Japan. They had 1347 responses. The primary endpoints were composite of death from any cause, NMI, and secondary endpoints was repeat revascularization for the target vessel. And you can see that there was no difference between PCI and CABG in the two groups, but obviously the PCI group required more intervention than the CABG group. This is studies from North America in terms of intervention and in terms of long-term outcomes in adulthood are a bit scarce because our experience is a bit more recent than the Japanese, but this is a pan-Canadian study to look at the outcomes of CABG and PCI in Kawasaki disease. The majority of these patients actually were children. There were 22 children. And obviously, there was an increased risk of reintervention in the percutaneous group as opposed to CABG. We still prefer percutaneous when it can be done over CABG, only because when you do CABG, we're looking at the longevity of the graft in a 2-year-old as opposed to doing a CABG in a 40-year-old. So we try to save time with percutaneous intervention as much as possible. You can actually see that there were 2 sudden deaths in the PCI group, and then some of the CABGs were for multi-vessel intervention. This is the National Japanese Survey looking at CABG outcomes in adults with Kawasaki disease from 2008 to 2019. 77% of them were male. The median age, so 343 patients. The median age of CABG was 39 years, anywhere between 32 to 72 years. Mortality was low. Now, the questionnaire was filled by 183 of these 343 patients that were discharged. So survival rates were pretty good at 5 and 10 years, but they were dependent on the left ventricular ejection fraction of the patient going in. So obviously it was worse in those with EFs less than 30 as opposed to those with EFs 30 to 60 or more than 60. So transition. Why is it important that we partner with adult cardiology and transition our patients? 1 in 600 children in the adults in the US will have a history of Kawasaki disease by 2030. This isn't, it is definitely less than what you see in coronary artery disease, which is 1 in 20 adults. Mortality is low, but morbidity is high. And less than 40% so close to 40% are lost to follow-up. That's a big number. 30% of patients in the US and 44% in Japan who are adults with Kawasaki have aneurysms. And 5% of those all have an aneurysm that's more than 5. So not, moderate or large. We did this survey this survey was done, it was multiple Kawasaki disease experts from North America, Canada, and we sent it literally to all continents, asking cardiologists and Kawasaki disease specialists what is their preferred hospital setting, for example, for percutaneous intervention, if it's a 6-year-old versus a 16-year-old. And you can see in the 6-year-old, even in the 6-year-old, they would prefer a pediatric center, but to have a pediatric and an adult interventionist, while if it's a 16-year-old, there will be more preferring an adult center with both pediatric and an adult interventionist. The same thing for CABG. The preference was always for to have the pediatric and adult expertise in the room caring for the patient. This is a very recent study that came out of Japan looking at the cardiovascular outcomes in adult KD. These were 798 hospitalized patients. Mortality was low. 33 of them presented to the emergency room and 28% ended up in the ICU. It's important to see that the age at presentation was bimodal, peaking at younger than 20 and then between 35 to 39 years of age. For acute coronary syndrome, there was only, the peak was at 35 to 39. So these patients are going to present to an adult emergency room. Also, the number of patients that had CABG, or the cohort of patients that had CABG was the highest in the 35 to 39 group, but you can see it's closely followed by the 40 to 50. Similarly for percutaneous intervention, 35 to 39, heart failure and arrhythmia, there was the 35 to 39 and the less than 20. These are clusters in young adults without obesity. You can see it's important to note that the second surge is in the 30s and that disrupted follow-up was associated with a higher associated with the worst outcome, be it mortality or admission to the ICU. So these patients who were presenting to the emergency room with symptoms, as opposed to having followed with having identified an adult cardiologist or adult congenital heart disease specialist to follow them, had a higher or worse outcomes. So that talks for the need for lifelong follow-up programs, systemic healthcare transition, and increased awareness among adult healthcare clinicians. And this is a call to action paper that was put in place in 2021 by the American Heart Association, describing the responsibilities of the referring team, which is the pediatric team, to transition this patient to partner with adult with our adult colleagues to confirm integration of these patients in the adult world. And you can see that we start at 12 years of age with the transition, making sure the patient is aware of their disease, they know the severity, they know what they need to do, they know how to care for themselves, and slowly transferring and integrating them into adult care. Another thing we have to talk about when it comes to bridging the gap, the data we have is data from North America and from Asia, where there is heightened awareness of Kawasaki disease. I mean, Japan is talking about policies to have 0% aneurysms, which is probably hard to achieve because there are patients who will still present with aneurysms at baseline, but that's every general pediatrician in Japan knows about Kawasaki disease. They actually, those who have small aneurysms or very minimal cardiac involvement are followed by the pediatrician. And then we come to other parts of the world and we see that we don't know what, we don't really know what the incidence of that disease is. We know that there is data that shows, at least in the Arab world and the Middle East, that there's a high rate of delayed treatment and a higher rate of aneurysms that has been reported in the literature. So during the pandemic, it allowed us to communicate with people from all over the world, and we realized that there are challenges for the management of Kawasaki disease and diagnosis of that disease in the Arab world that is particular to that region. And so the three of us, myself, Dr. Dada in Quebec, and Dr. Harashi in DC Children's, founded what is now known as Kawarabi, or the Kawasaki Disease Arab Initiative, with a vision to improve the diagnosis, care, and outcome of children and adults with Kawasaki disease across the Arab nations and ethnicities. We've had 24 centers, 14 countries, and 200 patients in the registry. We have had 5 meetings between Egypt, Dubai, Morocco, and Libya. And there has been several publications that highlighted from that initiative that highlighted that, for example, access to care, specifically to pediatric cardiology and to echo, once these patients are discharged from the hospital, varies. And it does favor large to mid-sized cities, while it's quite poor in the remote cities and rural areas. IVIG, which is standard therapy for that disease in the Arab world, is not always available. So at the time of that particular study here at the bottom, we had 19 institutions. So in 16 institutions, it was available, but in 2, it was available in the country, but not in the institution. And in 1 country, it was not available and had to be imported. So these are challenges that the US or North America doesn't face, but these are challenges that are faced by other parts of the world. So just a final talk on the importance of having a Kawasaki disease program to follow the patients. At Mount Sinai, the acute management is a multidisciplinary approach with hospital medicine, infectious disease, and pediatric cardiology. Once the patients are discharged, they're followed up at a minimum of 1 to 2 weeks and 4 to 6 weeks. This is considered the acute subacute period. And then the follow-up is tailored to the disease, to the coronary artery involvement severity. I'm the director. Dr. Hopkins is an ACHD specialist who handles the transition. You all know Dr. Zaidi. They both see our adults with Kawasaki disease. He's the head of our ACHD program. We offer echo, CT, MR, cath, stress imaging with echo, MR, and nuclear testing. Usually nuclear testing we reserve to the older kids and to the young adults, only because there's high rates of false positive in children. And we try to minimize radiation. We start transition at 12 to 14 years. And as I mentioned, adults are followed by in our adult congenital heart disease program, which brings a point as to whether ACHD is the home for these patients, or should it be adult cardiology, or both. And I'm happy to answer any of your questions.
Thank you so much, Nadine. That was an amazing lecture. Congrats on all the work you've done in the area. I think this is fascinating. We don't see as many patients, but we're probably missing a lot of it. So very, very important for all of us. So for everyone, please put your questions in the Q&A. If you want to stop sharing the screen so we can go to the Q&A.
Okay.
I will start with one question while we're waiting for the rest. So you showed that there's accelerated atherosclerosis, right? Because of the inflammation and even with the aneurysms more. Is there any data on statins, or should we be starting statins in people with Kawasaki or with aneurysms?
It's a good question. So there has been data on statins even in children, and for its anti-inflammatory effects on the coronary arteries. We try. It is kind of controversial whether there's not enough data to support its use in children, but yes, definitely in the young adults, we would put them on statins.
Okay, that makes sense, yeah. But I think more data and clinical trials are probably needed, right?
Yeah.
So another question I have is, do you test for ischemia when you have aneurysms, even if there's no stenosis? Could you still see ischemia in these patients?
So we actually so because when we do test, we do stress testing even in asymptomatic patients, because the majority of patients who present are asymptomatic because the stenosis is progressive, and often they develop collaterals. So we start with stress imaging, and if we see anything on stress imaging, we move to cath. Now, it's always a debate on, especially with those with giant aneurysms, do we do anatomic imaging and look at the CT scan or the cath, or do we do stress imaging? And that's always a discussion we have. But when we're practicing in a setting where all these modalities are available and the experience is there, then for example, in giant aneurysms, I definitely get a baseline CT on all of them, somewhere between 6 months to a year. And then it kind of allows me to see how much, whether there's any stenosis developing or not. But I would also follow that within either another 6 months to a year with some sort of stress imaging, be it stress echo or stress MR. And we're fortunate because, stress MR is a very high resource setting. You need the nurse, you need an anesthesiologist, you need your technician, you need your interpreting physician. And so we are lucky that we partnered with our adult colleagues, where they offer us some of the resources and we offer the rest. And so we do it together.
Thank you very much. We have a great question from Rob Osfield. He says, thank you for the talk. What are your thoughts regarding the use of colchicine in KD patients?
The use of colchicine in KD patients, I want to say that it has been described in patients who, like case reports in patients, I want to say in patients who are resistant, but I'm not familiar with the use of colchicine in aneurysms or to promote coronary artery health or to prevent further progression of disease.
Thank you. Thank you very much. Yes, I guess my question about the aneurysms was because thinking that the aneurysm could cause ischemia by itself, despite the presence maybe of no stenosis.
Yeah.
So together with that, do you ever intervene the aneurysms, or it's always medical therapy, or how do you make that decision?
Yeah. So we combine the anatomic imaging with the stress imaging. So for example, in this particular patient, like we are trying to determine, okay, we saw inducible ischemia, we have collaterals, are these collaterals adequate or not? Like the first patient I showed, the baby, that had 90% LAD stenosis, and there was not much collateral formation from the right. So we didn't do any inducible testing. This patient immediately went for a cabbage. The same thing happened with the right. So we determined that stenosis is more than 50%, more than 70% it was at the time, and there was not enough collaterals. Collateralization from the left, so that patient was also intervened on, and it depends on the degree of the stenosis, how much collaterals there is, what the stress imaging is showing us, and then symptoms or not. But a lot of these patients are asymptomatic.
And I heard that you're using FFRCT in some of these patients as well. Is that true?
Yes, we have, but the thing, we have used it in some of our patients. And there is data on FFRCT showing that it correlates well with NKD patients with obviously invasive FFR, but it's in children we use it more in the young adults, because in children the spatial resolution and the size of the coronary artery is pretty small, and then when it becomes stenotic it becomes even smaller. So we have spoken to some of the companies and they said it's hard to actually use it when the arteries are small.
Well, thank you very much again for this amazing lecture. And so I went to your symposium and it was amazing. So maybe you want to tell us about it. Are you doing it next year again?
So actually, thank you. And actually, for everybody, Leandro spoke at my symposium as well, and he gave a great talk. So the symposium this is the first symposium this is the first symposium in general on Kawasaki disease to bridge the gap and to kind of start a dialogue between pediatric cardiologists and adult cardiologists. Dr. Zaidi allowed me to use the ACHD platform to have this conference. And we had speakers from all over the world and attendees from all over the world in person and on Zoom, talking about Kawasaki disease, how different it is from the involvement from atherosclerosis, what interventions could be done. Do adult criteria for interventions apply for patients with Kawasaki disease? How do we transition? Why do we need to partner? And it created a lot of interest in other cities to do a similar conference. So it's probably going to go either to the Midwest or the West Coast. And it might come back to New York in 3 years. And that's to allow, one, for new science to come. And also because there are big KD symposiums that will be happening in the next 3 years. So, we want to make sure that we're working together as opposed to competing with them.
For sure. Well, I invite everyone to attend wherever you have it. And thank you again, and happy holidays to you and all our viewers. And we'll see everyone next year.
Thank you, and have a happy New Year and happy holidays.
Thank you. Bye-bye.
Bye.